to this day, I don't think I've ever gotten a major grant that wasn't lovingly handcrafted by me before it went out the door, starting with the aims and going through the process. Not to say that I didn't have amazing people working on different aspects of the grant with me and methods and statistics and a lot of different sections of it, working as a team. But that final product going out the door that really articulates the clinical relevance and the innovation and lays out your approach, how you're going to do this, and the impact and the benefit, that's a skill set that you have to have as a successful researcher.
Yeah. So for those listening who want to, are good at writing papers, good at reading papers, good at their clinical work, now they want to do the grants and they want to get it accepted. What advice do you have to give them on where to start and how to be successful?
Welcome to the Deep End. Today, we're honored to be joined by Dr. Peter Rubin, a globally recognized leader in plastic surgery, body contouring, and regenerative medicine. Dr. Rubin is the UPMC Endowed Professor and Chair of Plastic Surgery, Director of UPMC Wound Healing Services, and a Professor of Bioengineering, just a few of the many leadership roles he holds at the University of Pittsburgh. He's a pioneer in adipose-derived stem cell research and has helped shape the field of body contouring after massive weight loss. He has led major initiatives to advance reconstructive care for military veterans and has served in leadership roles across ASPS, AAPS, and IFATS. A dedicated educator and mentor, Dr. Rubin has published extensively and helped train the next generation of academic plastic surgeons. He recently brought his expertise to a national audience on TLC's 1,000-Pound Sisters, performing reconstructive surgery after massive weight loss in the season finale. Let's dive in.
Dr. Rubin, thank you so much for joining us tonight on the Deep End podcast. Many people asked to get you on as a guest, so we're incredibly honored to have you.
It's really a privilege to be here. Thank you so much for having me.
Of course, yeah. And you're somebody that, I look up to a lot just in the world of academic plastic surgery and just the world in general of surgery. And with your journey into plastic surgery is incredibly distinguished and as a chair of a department. And what do you think, can you tell us a little bit about your journey into plastic surgery and what initially drew you into the field?
Certainly. So, I had an early exposure to plastic surgery because my dad was a plastic surgeon. So I'm one
Oh,
of
that's
one of a growing number of second generation plastic surgeons. And my dad was an academic plastic surgeon. He was a burn and plastic surgeon in World War II, actually, and became a professor of plastic surgery in New York and ran a residency program. And I was very inspired by the passion that he had for the field and how it really appealed to his creative side. He was very artistic and very creative, and he was an educator. So there were a lot of things about it that really appealed to me. And like most kids, you try to pick a different path than your parents. And I knew I wanted to go into medicine. I was really drawn to medicine because of the science and physiology and the ability to help people. And as I got through all my rotations in medical school, really settled on surgery. And then within surgery, pursued a general surgery residency and was very interested in plastic surgery, but I wanted to see the full breadth of the surgical spectrum and ended up really being drawn in the end to plastic surgery. That was my true love, and have just had a really wonderful time in that career.
thinking back to your childhood. What do you think you enjoyed doing outside of school, or were you always academically inclined?
I enjoyed playing hockey. I wrote for my school newspaper in high school. I was in the theater production crew. I wasn't a performer, but ran the light crew and
That's
really
cool.
enjoyed that kind of creative side of things. And, so I definitely had a lot of interest out of science, but I love science. I grew up going to science camp in the summers, and I grew up in the New York area in Long Island and didn't appreciate the value of it at that time. But I went to science camp at Cold Harbor National Laboratories,
Wow.
which, was close to our house and was really a neat experience.
Yeah. And then you went on to train at institutions like Harvard and Mass General. And I trained at Hopkins for general surgery. And I know how it is to train at a place that has such like an incredible legacy where really the writing's on the wall when you walk down the hallway and you see everyone that's come before you. But how do you think that an experience like that kind of shaped who you are today as a chair of a department?
I mean, being around passionate leaders in plastic surgery and great contributors to plastic surgery is a wonderful experience. And you try to learn as much as you can from all of them. But I really had a great respect for the history of the specialty and the tradition of the specialty, the tradition of innovation and excellence, and really striving to do better. And the fact that you could literally come up with new procedures, new technology in the specialty that could be applied, and it was a very fast moving field. So it was really a great experience, and especially in the Harvard system, between the multiple hospitals, between the MGH and BI
Mhm.
Deaconess and Brigham and Children's Hospital, you had such a broad exposure to so many different people with so many different perspectives. I found that really very valuable.
I know part of your interests are body contouring. So what kind of drove you towards that specialty in general? And one thing that I'm curious about too is the role that you think all of these weight loss medications are playing these days, such as Ozempic, and how that's changing the field of weight loss surgery and body contouring.
Sure. So when I was training in the late 90s, I had this flow of patients coming into our resident clinic that had been through massive weight loss. And that was at a time when there was a really steep rise in the number of bariatric cases, but it wasn't, where it was today. It was kind of in the earlier growth phase. And these patients had such a different life after weight loss. They had been so positively impacted by the bariatric surgery, and they had problems with excess skin. And a lot of the issues that they were complaining about and procedures to correct them hadn't been well described in the literature yet. And I saw that as an opportunity to really help develop some of these procedures technically, but also the comprehensive care of the weight loss patient from an
Mhm.
overall medical and psychosocial perspective, and really help dig in and build and develop this area of practice. And I knew it would be very impactful. I knew that this was a growing field. It was obviously a very efficacious procedure, and the obesity rates were really skyrocketing. And I knew this would be very technically challenging. And the patients that I was taking care of through our resident clinic were, they were very happy patients, and it was very gratifying. So that's how I got interested in it, early in my career, and I thought this is really a wonderful area to pursue. And to answer your question about the role of GLP-1 agonists, I think those are just revolutionary,
Yep.
and they are having such a positive impact on health with metabolic disease and diabetes and many other problems that we hadn't thought they might be helpful for. And so we're seeing more and more patients who are going to be seeking plastic surgery after successful weight loss through GLP-1 agonists. Another aspect of this is that we have a lot of patients who have been through bariatric surgery and had plateaued, and they plateaued at sort of a high BMI, and then they went on the GLP agonists
Mhm.
and they've lost weight, and now they're showing up in my office. So I'm seeing more and more patients now who may have had their bariatric surgery in 2008 or 2013, some really long time ago. And the history is that 18 months ago or 24 months ago they went on a GLP agonist, and now they've gotten by the plateau, and
Mhm.
they've lost the rest of the weight. So it's a very valuable, not just for non-bariatric patients, but even for helping the bariatric patients get further along.
And no, 100%. A large part of my practice is body contouring. It's incredibly rewarding. These patients do so well with the weight loss that giving them that extra help to improve their quality of life is just, it's absolutely rewarding. I truly love it.
It really is very rewarding, and you see patients from all different walks of life and all different areas of the region, and
Yes.
it's really neat.
You
Very
know,
diverse population. Absolutely. That's something we're actually really digging into right now. Been very, very inspired by what I'm seeing out there.
Yeah. So now, shifting a little bit to talk about your leadership. Like I said, you're somebody that all of us, I can say, across the globe look up to. And you've had many different leadership roles in major societies, internationally, ASPS. How have those experiences shaped your perspective on plastic surgery globally?
I would say a very impactful takeaway is how privileged we are to be part of this specialty and to be part
Absolutely.
of this community of leaders in plastic surgery. I say that very sincerely. I mean, every one of these organizations that I've been involved with, whether it's ASPS or ISPRESS, or ISAPS or American Board of Plastic Surgery, you interact with this amazing group of people who are really committed to moving the specialty forward. You learn a lot from them. You share perspectives and ideas, and you work together to solve the problem of the day. And it's part of that evolution of the field. So that's I mean that's just been an amazing experience to be a part of those organizations and to have a leadership role.
What would you say is the initiative or project you were most proud of during that time?
One of the prospective things that we worked on, that I worked on as president, was sort of revamping our approach to digital education
Mm.
and getting on board to rapidly improve and update our digital education offerings, and even how we do a lot of the formatting for that programming. In the reactive phase, we were dealing with the onset of the breast implant checklist that was coming up before the FDA. I'm very proud of the fact that we collaborated closely with ASAPs and really brought things together, brought members of our specialty together around that issue so that we could be stronger together when we were working with the FDA. We put out also a joint statement between ASPS and ASAPs on gluteal fat grafting safety, really digging in further to not only the technical issues, but some of the practice issues around gluteal fat grafting. In other words, clinics, high volume clinics that are not well certified or inspected, that use assistants who may not be qualified. So there are a lot of these issues we worked on during my tenure as ASPS president. We were initiating or implementing changing governance, and that was the brainchild of Joe Losi to redo the whole governance structure of ASPS so it would be more representational. Instead of having a board of directors and an executive committee, we would have a single board of directors and then a council of representatives so that more subspecialties could be recognized. So I mean, those were just some of the things that I worked on. And again, in those roles, you're part of the evolution. You're a link in the chain, and you want to keep prospective initiatives moving forward for the growth of the society and the specialty, and also make sure that we have good responses to issues that are cropping up, whether they be regulatory or other threats to what we do.
And it's funny that you both were kind of side by side as presidents of the society. And on this conversation of leading a department, I was sort of always interested in the topic of department versus division. I know that there's obvious advantages to departments. We personally, I was interested in looking at kind of how many divisions have progressed on to departments nationally. We published this in PRS, I think 5 or so years ago. What are the obvious advantages of being part of a department? And what do you think the future holds for plastic surgery? Do you see one day all of us becoming departments of plastic surgery?
And I think it is a path that all programs should be on. You look at other subspecialties, surgical specialties like otolaryngology, orthopedics, neurosurgery. They've all spun out as departments. Our training process is very well separated from general surgery. Right now, what we do is very disparate from general surgery. We truly are a very distinct specialty with our own board certification, our own categorical residencies coming right out of medical school. I think it's very important because it gives us more autonomy. It gives us a seat at the table. And if you don't have a seat at the table, yes, you are on the menu. And it's very important that we can sit shoulder to shoulder with all the other department chairs at the meetings with the dean and the health system leaders and be able to chart our course with a bit more autonomy than if we were a division of a larger department.
as plastic surgeons, we're incredibly productive. We work really hard. We operate a lot. It must be hard for a department of surgery to give us up because if we're operating a lot, bringing a lot of money into the department of surgery, doing good research, etc., why would a department of surgery ever want us to not be a division within their department?
And they have a very good argument for that. At the time that I was taking over the plastic surgery program, I give great credit to Dr. Tim Billier, who's an amazing leader in
Yes.
an amazing leader in surgery in the surgical community. He recognized the argument that if we want to be a top program, that we need to make this transition, and that other top programs were becoming departments. Look at the time, Andy Lee, who was my mentor, terrific mentor, was leaving to go to Hopkins, and they were making a department for him at Hopkins. That was sort of one of the arguments that I used at the time. Look at the trend, what's happening. Look at all the places that are becoming departments, and a lot of other departments were programs were turning over to departments at that time. UC Irvine, there were a few at that time that were switching over. And so that was also a very compelling argument. Dr. Billier had a large enough department and was very system oriented and a big picture thinker, and could sort of get beyond that and say, yeah, that this is meaningful. Early in my tenure as a department chair, he was a significant mentor for me.
Yeah. Yeah. And I actually interviewed with him, and Julie Freshlage, who was also a guest of this podcast, and she talked about how supportive she was of Dr. Lee in his pursuit of making it a department. And I think you need those special people, kind of almost like a special mentor that see the benefits to allow it to happen. You guys are incredibly, incredibly productive when it comes to both basic science and clinical research. And Francesco's a really good friend of mine, and I have a lot of good friends within your department. I mean, I feel like within Penn and Pittsburgh, we're almost like, siblings.
Yeah,
but
for sure.
But what has made you so successful when it comes to the research that you do, the NIH funding, et cetera? Because when you think of a department chair, you think it has to be somebody who can play that role really, really, not only plays the leadership role well, the clinical role well, but also the research. So what has made you so successful when it comes to research?
I look at leadership of our department at University of Pittsburgh and UPMC as having four major pillars. There's the outstanding clinical care that we strive to deliver every day. There's the cutting edge research that's going to define the future therapies in plastic surgery. There is the excellent education that's going to develop the next leaders in the field. And then there's the service role and professional development, helping people build their careers, helping people become leaders. Like many people who have become leaders in plastic surgery, I grew up as a surgeon scientist, like yourself. I spent 2 years at Mass General training in surgical science, both in transplant immunology with Andy Lee and also tissue engineering. Had a great passion for that. I mean, you're not going to be successful in research unless you really enjoy it, unless you really enjoy that the creativity and innovations. I was very passionate about that. I kind of had a fire within for it, and I kept that going. And the real key to making that happen is to get wonderful people around you. I was absolutely fortunate to partner early in my career with Dr. Casey Mara, who's a PhD, a tissue engineer and polymer chemist. And we built the lab together, and we had each other's back. And we knew that we were bringing complementary skill sets to the table. And we started out with me and Casey and one tech between us. And we've grown to a pretty big enterprise over more than a couple of decades, and brought on other faculty and really built a great center for scientific education and for productivity. So I think building that infrastructure, partnering with basic scientists is really, really key, and getting good people around you who are aligned in the mission. And it's not easy to do. You have to really get the right people on board, and you have to I have to partner with them, and then bringing on other people who, like you mentioned, Francesco. We're so proud of Francesco. He just got his first major federal grant, and we're trying to really have a supportive infrastructure around that. So about 10 years ago, in addition to the basic science infrastructure, I started to build a clinical trials infrastructure and brought on some great staff. Our clinical trials director of clinical and regulatory affairs is a seasoned nurse manager in the research area, and I think she'll be with us now for about 15 years. And having that supportive infrastructure, you can't do major clinical trials without having that kind of staffing.
Yeah, no, absolutely. And I think one of the things that you said is key, and it kind of on a much smaller scale, when medical students or residents ask me about the research time off or, getting involved in research, et cetera, I tell them try not to worry about the number game, because you have to, if you love something, then you will be good at it. Even if it's one publication a year, if it's something that you're incredibly proud of, and basic science is way more challenging to get papers out. So I think I love what you said where, you had the passion, and so that obviously helped. And I absolutely love research. I love thinking of a study, getting somebody else involved, putting it to paper, and then having it impact patient care. There's no better feeling.
It's amazing. Yeah, I agree with you 100%. It's such a great thing. And the other thing I'll say about how do you stay successful in research, to this day, I don't think I've ever gotten a major grant that wasn't lovingly handcrafted by me before it went out the door, starting with the aims and going through the process. Not to say that I didn't have amazing people working on different aspects of the grant with me, and methods and statistics and a lot of different sections of it, working as a team. But that final product going out the door that really articulates the clinical relevance and the innovation and lays out your approach, how you're going to do this, and the impact and the benefit, that's a skill set that you have to have as a successful researcher.
Yeah. So for those listening who want to, are good at writing papers, good at reading papers, good at their clinical work, now they want to do the grants and they want to get it accepted. What advice do you have to give them on where to start and how to be successful?
Where to start? So come up with some good ideas. Get some good senior mentors who are going to work with you. That's been invaluable for me as well. There have been a number of senior scientists who have helped me, especially early in my career, and that's just been incredible. Like people who are giving back, people who are like, okay, I see you're passionate about this. I'm going to help you about this with this. It's your project. And I'm going to give you advice. I'm going to review your aims page for you. And by the way, you want to spend the most time on your specific aims. Develop that one page, like spend a lot of time on that. But find some senior mentors that can help you. Make sure you understand the feasibility of the execution, and start partnering. The other part of this I'll mention for being successful in research is you can't do it alone. You have to. It's got to be team science, and you've got to have great collaborators across different laboratories and often, different disciplines that you can work with. And
Especially if we're surgeons.
especially if we're surgeons, exactly. Whether those are, immunopathologists or neurophysiologists, you name it, but all of these big successful, all the major successful grants that I've had funded have had an incredible team.
Yeah, no, that's a great point. Specifically when it comes to your role as co-director of the Adipose Stem Cell Center, what breakthroughs do you think are on the horizon in regenerative therapies?
So when you look at fat is super interesting to me.
Yeah, I agree.
And there are sort of three components to how you can use, or three major categories for how we can use fat therapeutically. And they intersect in a lot of places in a Venn diagram. And the first way, and we see this most commonly, is as a structural material that we can use to build a breast, to, build any structure that we want. The second way is through the release of growth factors, the secretome effect.
Yep.
And those can be the growth factors, those can be immunomodulatory effects. And it's funny because I was working with bone marrow stem cells back in Andy Lee's lab in 1994, and then 20 years after that, I circled back into using adipose stem cells into some DoD funded work for immunomodulation in VCA. And then the third aspect, or the third way to use this is for the plasticity effects of the stem cells. Can we transform adipose stem cells into other tissue types, whether that be liver or pancreas?
So,
And it's really cool. So that third aspect is the most nascent, and that's probably going to be propelled forward by CRISPR-Cas9 so that we can do a gene editing that will induce very directed transformation of these cells. Adult mesenchymal stem cells don't like to differentiate spontaneously, which is a good thing. So we're not full of teratomas. That's very nascent, and there's a lot of potential there. The real sweet spot right now is in the secretome effects. And so, for example, we're one of the sites in a trial using adipose stem cells for knee osteoarthritis in a phase 3 trial. That's a very exciting, again, for the immunomodulatory effects of the stem cells, using them to downregulate the immune system with chronic inflammatory diseases is another really interesting area where we may see some progress. And then, of course, mitigating radiation damage is a huge area. And we see that, in combination with the volume effects when we use that for breast fat grafting. So, but especially in mitigating radiation effects, I think that's going to be a very, very interesting area. And then one of the things that we've been working on our lab is clinically applicable fat cryopreservation, fat graft cryopreservation. And over the last 6 years, we've developed a device and a kit for which we have a lot of IP through University of Pittsburgh under NIH funding. And now we're moving to DoD funding for clinical trials on that. So one of the ways
really
to
cool.
deal with the challenges of fat resorption.
Yeah. I think that the radiation is something that really, really fascinates me because it's from an oncologic perspective, of course, it makes complete sense. It's just the negative consequences are really not good when it comes to a patient perspective. Fat grafting, I agree, is incredibly fascinating, the whole concept. And so you're the perfect person to ask this to. I have one idea for what my answer would be, but what do you do with the thin patient who has no fat to give? And so that's question number one. But another thought that I potentially had is, we can do epidermal autografts when it comes to skin grafting. We did it for a patient, for a young child at CHOP who had scalp necrotizing fasciitis and did epidermal autografts, and obviously that healed. It'd be really neat if we could do something like that when it came to fat, like maybe got a few fat cells and then we're able to generate enough for fat grafting in about 6 months down the road for these really slim patients that would benefit from it but don't have it to give.
Well, that is, a holy grail. And, 25 years ago, a key research question for me, or a key clinically relevant research question, has always been exactly that. Can we guide the directed growth of fat tissue where we want it in the shape and volume that we want? And we can't do it very well yet. We can differentiate, so we can expand. You can't culture expand mature adipocytes, but you can very well culture expand the pre-adipocytes, the adipose stromal cells. And once you expand them, you can differentiate them. So we've done a lot of work over the years with bioreactors and controlled release drug delivery systems to try and get those cells to differentiate and grow. And I think there's a lot of potential there. And again, that really is for me the holy grail, that thin patient. Can you put in a polymer disc of slow release growth factors and get the local fat cells to start to divide and grow into a breast?
Because otherwise, what would you do for them? Like, let's say you had a very slim patient that really, I had one patient who had, probably 0.01% body fat. What do you do for that patient?
You hope they have a twin sister who's got some extra fat on them, but it's challenging. And I've had to turn patients like that away. I have one that I'm taking care of right now who's very lean, and she knows very well I'm going to get as much fat as I can. At the end, you're going to have an A cup, and that's all
Yeah.
we're going to get.
Yeah. Yeah. Well, I appreciate your insight on it. And that's like a whole separate podcast in itself to talk about that, but it's very fascinating. Now, to kind of shift a little bit, another thing that I'm currently getting my MPH through UPenn because I'm a true believer in lifelong learning. If we're at institutions like UPenn, Pittsburgh, take advantage of the tuition benefit and get it. And I know you got your MBA. And
I
so why, number one, why did you get it? And then what did you take away from it? Like, obviously, I think you probably found it valuable in your leadership role, both within Pittsburgh, but internationally. But can you talk a little bit about what made you get it and the valuable takeaways from that?
did. Sure. So I was always very interested in the idea of doing an MBA. And one of the things you learn as a surgical leader is that we don't really have the same training and background as the healthcare executives that run our health system. And in fact, our background, as I mentioned before, is I was a good surgeon, I was a good scientist. So then you get promoted into a leadership job in surgery. And in a lot of other industries, they actually train you at that point with some leadership skills and some technical skills. Our colleagues in the military, when they get increased,
Yes.
when they become commanders, they get trained. Not the case in academic medicine. And I was in a very I've been in a very big health system. It's now a $26 billion health system. And I recognize that this is an incredibly resource rich environment, opportunity rich environment, but I needed to augment my skill set if I was going to be a good leader in a surgical department and take advantage of that. So they had started a executive MBA program in healthcare at Pitt.
Oh, that's great.
They had just started that. So I went and I talked to the directors there and applied for it. And I was, I was over 50 at the time when I started it. But like you, I'm such a believer in lifelong learning. And it was one of the most enriching things that I ever did
Yeah.
as in my professional career. And we would go to class. You would do one weekend a month in class, and it was 18 hours of classroom time in that weekend. And pretty much every hour of class, I would say, this is great. I'm going to use this Monday. And it wasn't just the technical skills, the accounting or the finance. I mean, that was good. We needed to learn the language, of course, but a lot of it really hinged on the organizational management skills and a lot of the things that were just not taught. How do you solve these management problems? And that was a very, very rich experience that I really enjoyed.
No, and you're right when you compare medicine to all these other you know, finance, et cetera, that where oftentimes they're guided in the correct leadership teachings and stuff where we're kind of maybe perhaps just that's always been our personality. We just kind of find it for ourselves and seek what we need, the skill sets that we need to do what we do. But I totally agree. And I'm interested in getting an MBA at some point. I took one kind of class through Wharton, just even it was something about, how to give a good talk. And
Sure.
what I took away from that was unbelievable. And I think as you mentioned that you got your MBA after the age of 50. I almost think we appreciate that so much now. Like I remember looking back to college and medical school and things like that. And I'd sit in class and I'd learn and I'd read, I'd study for exams. But now when we're actually seeking to learn and almost not forced to do it, it's so much more enjoyable. And I absolutely love it.
That's great. That's fantastic.
So, a few other questions that I had for you. These are kind of like getting towards the end of the podcast. Thinking about your research, your busy clinical setting, your time outside of the hospital. Number one, how do you balance it all? And what do you still like to do outside of work?
So I think that it is a little bit of a balancing act. It's more of an integration act than anything. When you have a big grant due, you're writing that grant the whole weekend. But when you're not, you've got to parentheses around your different parts of your schedule, whether that be a whole day, a half day. I have 4 kids, 15 through 20, 2 in college and 2 in high school. And I love spending time with my family, with my wife and kids. Love to cook, love to bike and hike, do things in the outdoors, love to ski.
And they have to be understanding too of you just on a weekend having to write a grant. You have to have a good significant other, I'm sure.
But she's wonderful. I mean, she's been with me, since college and has seen me through, medical school and
So
residence.
she knew what she was getting into.
I don't think either of us knew quite what we were getting. I don't think any of us going into academic surgery really know what we're getting into until we're there. But she's been a great support, great life partner. But yeah, I love spending time with my family, going to whatever activities my kids are into, whether it's theater, going to their theater shows, theater productions, poetry readings. Some are athletes and play hockey. I have a couple of girls who play ice hockey and going to see their hockey games. I love Pittsburgh sports as well.
Yeah.
On the medical staff for the Penguins as their team plastic surgeon. That's a lot of fun. So enjoying the city of Pittsburgh and
Yeah. So it's nice to tell the audience that you can do everything that you do and still have time for family, for kids, enjoying life, going to games. And I always like to hear that as well. I have 3 going on 4 kids. So much. Thank you so much. Now looking back, is there anything that you could say, I wish I did this differently? Like, I have this one regret, and if I could go back today, I would do this differently. Is there anything that sticks to mind?
no one single regret. I could speak for hours about the hundreds of wrong choices I've made, mistakes I've made in medicine and leadership in all areas of my life, like any of us. And, those have to be learning experiences. And under those conditions, by design, you have to really treat those as learning experiences, just like an M&M, like a life M&M. So, there's a gazillion of those, where I've not made the right choice, but I've made the best choice with the information that I had at the time. But I don't think there's, one single thing where I say I wish I had done things differently. The things that come at you are the things that come at you, right?
Yeah, no, it's true. And it's good to have that perspective to know that it's kind of all part of the path and you learn from those. And that's what some of the mistakes or the bumps are why you got to where you are potentially.
Yeah, I mean, who among us has had it easy? Has had like that
Yeah.
golden smooth path where, you know, they've made all the right choices and nothing's gone wrong. I mean, we're tested every day in what we do as plastic surgeons.
No, for sure. And so if you weren't a plastic surgeon, what would you have been?
I think
Hockey?
probably not, but I think something still in the scientific and in the life sciences, whether that's an innovator in a pharmaceutical company or something in the technical creative area.
Yeah.
I think growing up, I really wanted to be a marine biologist, and I decided that wasn't really a great path. At the end of the day, I like medicine a lot better, but I think something in the innovation arena.
Do you listen to music in the operating room? And if so, what music is your choice?
Top choices, it sort of vacillates between Indies gangster rap and
That was a good time.
Soul Cycle Radio, which has a great beat on Sirius XM, and Roots Reggae, which
Yeah.
has a great melodic beat. So those are what you'll hear in my OR.
Those are great choices. And then what would you say is your favorite surgical instrument that you can't live without?
22 blade. And most people
You're the first to say that.
most people don't even know what it is.
What is that?
It's about the largest size scalpel blade that you can get, and for body contouring, it is just a
Wow.
wonderful, wonderful instrument. So I always say
So special about it.
it's got a big profile, big belly of the blade. It holds an edge really well. So for long incisions and for shaping breast parenchyma, for example, it's just a really useful instrument.
Yeah. Well, that's I'll have to ask for that next time I do body contour.
They may have to special order it.
Okay. Well, never mind then, but I'll look it up at least. Well, anyways, thank you so much for joining me tonight. This was an absolute blast. And sometimes I wish that I could talk more than just 45 minutes to an hour, but I learned a lot. I know our guests are going to be very happy. So thank you so much.
Thank you for the opportunity. It's really been a pleasure and a privilege.
Thank you for listening to the DIEP End Plastic Surgery Podcast. If you've enjoyed today's conversation, please like, subscribe, and leave a rating on Apple Music or Spotify. Video from the podcast is available on Instagram and YouTube at the DIEP End Podcast. Join us again soon for more conversations with luminaries and experts in the world of surgery.